Well, that's a tough act to follow. While I wait for my slides to come up, can we just give a round of applause to Marwan and the whole planning committee for Houston Shah, and then to Balim Senman and the entire executive board, and Jason Katz, the inaugural president, for this wonderful venue. It's truly my honor and privilege. And what I hope to convince you in the next few minutes is why Dr. Miller here completely missed the mark. And yes, I will hire anyone with interest to Dr. Van Diepen's point is a little liberal here, so I will refine the topic. Admittedly, cat's out of the bag. We did not share slides in advance, so apologies for some of the duplication. But here's really how this thread, I have receipts that went between Dr. Senman and myself. So you're interested in one of the debates? Can I please change the title? What do you have in mind? How about arguing for a collaborative co-management model? Cardiologists, critical care physicians. Why don't you just stick to the assignment? You sure? Yeah, you can change it after your title side, and let's see how it goes. Done. So what I hope to convince you in the next few minutes is this very provocative title of I will hire anyone with expertise or certification in cardiology and critical care who can attend in a collaborative co-management model in my CICU. And I have several reasons, but I'm gonna bury the lead a little bit here. Number one, coming from the University of Michigan, it's all about the team. Yes, Dr. Miller, thank you for sharing the only study that we have outside of the US that shows support for critical care cardiology being associated with pre and post model with improved survival. And you can see it beautifully there, both in CICU and hospital mortality, both CV and non-CV death. The devil's in the details, and if you actually look at the central illustration, more importantly, read the paper, as I'm going to show you here shortly, there are a number of changes that actually occurred during this implementation of this model, which included multidisciplinary team-based staffing. And in fact, Dr. Morrow, who's one of the sort of leaders of this field and one of my mentors, articulated this well in the accompanying editorial about evidence-based redesign of the cardiac intensive care unit, and noted as an uncommon variation of high-intensity staffing, a general cardiologist and a general intensivist were also present during the daytime and overnight provided backup. That's interesting. So the question here is, with a change to physician expertise, yes, there was high-intensity staffing, but a transition to ICU-based staffing based on modifications for rounding, supervision, nocturnal coverage, and a restructuring of the entire multidisciplinary team, how do you know which of these elements actually influence the associated survival benefits seen in this study? Again, the only study that we have to date. I think this articulates it beautifully. How can we meaningfully contribute to the evidence-based redesign? CICU and hospital leaders must examine their own population and patterns of care and tailor the organization of the CICU to the needs of their community and practice environment. He already showed you this beautiful data. Again, the literature is a bit scarce, so a call to action for many of you in the audience. But what should be articulated here is in this collaborative model at the University of Maryland, interesting that you're calling it a level 2, that mandatory intensivist consultation for those mechanically intubated patients, 360 patients included in this study, was associated with reduced vent-free days, CICU length of stay, hospital length of stay, charges. We'll ask for Ms. Fisher's comment on that here momentarily, as well as Apache-associated adjusted mortality. So as noted here, not only were there significant reductions in associated mortality, but 28% of the CICU directors, many of whom are in this hospital, said implementing a full-time cardiac intensivist model is not feasible at their respective institution. And so perhaps this is an opportunity that warrants further study. That's coming next. Maybe the real key here that we should all be discussing is that high-intensity staffing is the key. So I present to you figure 1, which is from Dr. Miller's work that was published in JAHA, conveniently left out of his talk, that looked at the transition from an open to closed unit. That's a bit antiquated now. We talk a little bit about high-intensity staffing, but this central illustration actually does all the work for me. It's unclear exactly who was rounding and when they were rounding in the pre-model in the open CICU, but afterwards, I don't see the word critical care there, Dr. Miller. Do you? Where's the word intensivist? And so I see heart failure, I see interventional, and I see a house staff rounding team. And let's see what that was associated with. Well, it was associated with improved in-hospital mortality, improved CICU mortality, maybe not meeting the mark on 30-day in 1 year, across a number of conditions, so subgroups looking at cardiac arrest, respiratory failure, which Dr. Berg taught us is the most common indication. And it seems like the Yale unit is struggling a little bit with cardiogenic shock, which we'll get to here momentarily. No worries, decompensated heart failure is an opportunity that your colleagues a little bit down south in New York at Montefiore, Danny Sims and so forth, published that a full-time CICU-based staffing model by heart failure cardiologists actually showed similar results. So maybe it's really just high-intensity staffing and having dedicated CICU physicians that seems to be making the difference with both adjusted CICU mortality and MCS patient mortality. Happy birthday not only to the Society of Critical Care Cardiology, but also to the Cardiac Intensive Care Unit. And this is a wonderful article that I encourage all of us to read in circulation, published by good friends and colleagues, Drs. Aaron Bahula and Dr. Moore at the Brigham. And even here, they note that it could be either CICU-based staffing or integration of a cardiologist and a critical care specialist that is present in managing these current patients. All right, number 3, a collaborative co-management model is associated with improved survival in shock teams and networks. And yes, he showed you the statement that was published recently. It only took 2.5 years and 35 reviewers. Yes, a critical care cardiologist can do a lot of things and can do actually a lot of things really, really well, as shown during the COVID-19 pandemic. But what he again articulated for me, thank you for highlighting, I'll show the same slide. we indicated to achieve optimal patient outcomes in a level 1 CICU, and there were a number, 14 to count, of critical care cardiologists that were on that document. It included both critical care cardiologists as well as a co-management model. Furthermore, at Inova, and so I'll get a little bit institution specific since the question that we're debating here is whom would you hire? I would hire a cardiologist and or intensivist with experience and expertise in critical care. And you can see this teams of teams approach that really shows how nimble and agile one needs to be. In fact, Inova has one of its significant contributions from Dr. Tarani and colleagues has been showing that shock teams have been associated with improved survival. That was a single center experience emulated at the University of Utah by Dr. Drakos and colleagues, also emulated by Dr. Lee and colleagues at University of Ottawa. But to date, as far as I'm aware, only at the Inova Schar Heart and Vascular have we been able to show from a regional network of care whether you present to any of those 34 referring centers that are categorized as level 2 or level 3 in the community, or to the flagship, the red dot in the middle, that's Inova Fairfax Hospital, your 30-day mortality, your in-hospital mortality, your major bleeding complications, major vascular complications, stroke, and other major adverse cardiovascular or cerebrovascular events are statistically not different. That's what a heart failure and critical care specialist co-management model can get you. Furthermore, a heart failure cardiologist team at the University of Utah has shown the cost effectiveness of a shock team approach in refractory cardiogenic shock. I don't really know what this slide means, but supposedly it shows us that with a Monte Carlo simulation, about 150,000 qualities you are noticing some benefit through a shock team approach. And this has, of course, been explored at the inaugural meeting, the precursor to this that was done at Sky Shock back in October by Dr. Senman, Katz, and other colleagues, and a paper, as you see here, is forthcoming. Number 4, Dr. Miller, you alluded to this. It's all about the numbers, and I'll add a little bit of geography. So as Dr. Katz published this seminal paper that really catalyzed my interest in the field almost 20 years ago on cardiology and the critical care crisis, it spawned this document that I was fortunate to contribute to 10 years ago, really contributing to the supply and demand of the CV workforce at large, which of course includes some of the critical care issues. And if we actually look at the American Hospital Association statistics, which I'm sure you read every night, there are 5,000 hospitals in the country. You can look at the geographic distribution there. It's unclear and unfortunate the care we're providing in at least the western part of the country here. There's now fewer than at least 10% that are dual boarded and certified, whether you buy it as 397 or 164 and counting. It obviously is insufficient to meet this need. 1,700 teaching hospitals, by the way. Furthermore, if you look at the number of standalone critical care medicine programs, that's far insufficient to meet this growing demand, certainly over the next decade. And then finally, what's even more sobering and should be a call to action for this community is that the ratio of applicants to positions for critical care programs is actually falling over this time period. And number 5, and I actually do mean this quite sincerely, a 1.0 critical care cardiologist FTE is highly variable, and it's really incumbent upon our society and our community to help define this for health systems and administration, and more importantly, for us to take care of each other as a community, because it really can lead to burnout. And there have been a number of calls to action regarding critical care staffing being in critical condition, and to address this burnout condition. So my final take-home points, and then I welcome your cross-examination. Multidisciplinary team-based care, and perhaps not necessarily critical care cardiology staffing, seems to be the dominant motif in all of these observational studies looking at CICU-based models. So I again submit to you, high-intensity CICU-based staffing is the key. As we showed in that AHA scientific statement, a collaborative co-management model of cardiologists and critical care physicians has certainly been associated with improved outcomes in a heterogeneous condition like shock. And the current numbers of dual certified cardiologists and fellows in training don't meet the present or even the anticipated or burgeoning need for these patients at hospitals across the US. And finally, our critical care cardiologists can't be working 20, 30, 40 weeks annually and expect to sustain this as a 20 to 30-year career. And so it's really incumbent upon us to think about those workforce projections. Look forward to your conversation. Hopefully you agree that this was a knockout. And question to you, whom would you hire?
Thank you so much. So I think the thing we should really get down to is speaking about the reality of everyone's current situation. And so I'd like to start with at least the CICU directors. Can you speak to what is your current staffing model and who is the person leading the charge of your CICU?
Sure, I can get us started. Hi, everyone. Thanks for having me. This is wonderful to see so many faces in the audience and great presentations from both of our speakers. So I wanted to expand a little bit before I answer that question on something Dr. Sinha mentioned. So I want to take a little bit of a public health lens to this. So if we look at the American Hospitals Association, there's not a ton of data about CICUs, not a ton of granular data. But we do have a community survey from 2022 that looked at just the non-academics hospitals in the country. And there are 60,000 ICU beds, and 15,000 of them are critical care cardiology beds, cardiac ICU beds. And we have less than 500 dual-boarded cardiac intensivists. So huge supply-demand mismatch. So I personally think that beggars can't be choosers, right? If we pulled all of those 500 out of academics and plugged them into the community, we still wouldn't have enough critical care dual-boarded cardiologists. So I think we have a huge problem here. I think we can't be too rigid in who we let staff our CICUs because we ostracize the community altogether in that way. To answer the question, so we actually have full-time home crit staffing, daytime and nighttime. So there is actually no pressure to hire dual-boarded cardiologists. I also practice in a level 2 CICU that is set within a larger academic center with access to level 1 CICUs. So for me, I don't feel the pressure to hire dual-boarded cardiologists, but I think this is something where one size doesn't fit all, and each hospital system, each center, each department has to vet their needs and what kind of is a good fit. And the one other thing I'll also add, and maybe this is a little bit of a hot take, but if I have 2 CVs in my hand and I have a dual-boarded critical care cardiologist, but perhaps they've only been doing 4 clinical weeks a year or something like that, maybe they're more research focused, and I'm hiring for a very clinical job, and I have a general cardiologist who has a critical care interest and has been doing 20 weeks of CICU at their previous job, I would be inclined to hire that latter person. So I think the person comes before the pedigree for me.
Any of our other CICU directors?
Hello.
Or
CICU.
anyone else?
So anyone who's ever been out to me with me would say that we're obviously going to order the beef Wellington, but there's also appetizers on the way. And I think right now, clearly, we're going to be wanting to staff our ICUs of 5 to 10 years from now with critical care cardiology, but they aren't there. And although you're finding people here and there, it's a finite pool, pulling them to different geographic locales is hard. Northeast Ohio, particularly in the winter, is a tough sell. And so we live in a reality where we have to say, if you have an excellence in critical care, if you have a passion for it and you're good in the space, then it's reasonable to take the hire now. But I think the question is also, is that what we want long term? And where do we see ourselves moving as a field, not now, but 5 to 10 years from now?
Yeah, just to expand on that, so we do welcome and importantly are hiring critical care cardiologists at Inova Heart and Vascular. Obviously, the debate is among friends and colleagues here. But I will say it is incumbent upon us during this transition period. How do you accommodate that? I know that both Dr. Miller and Dr. Katz are Tar Heels, and we can't just have the Jordan rules, right? So when they're on service, this is how we round and this is what we do. And when somebody else is on service, it's a completely different structure. So, and that's been part of the challenge in integrating in our model. So we actually have critical care physicians that provide 24/7 staffing through 12-hour shifts, but are co-managed and round 3 times a day with our cardiologists on service, 70% of whom are heart failure docs, and the other are interventional with shock and cardiac arrest and relevant expertise. And that's really worked well for a 24-bed cardiac ICU. We have a separate 24-bed cardiothoracic ICU, but and we're now building another 24-bed cardiovascular-related ICU because of the emerging need within our community in the DMV, as you saw there. I also do want to make an important plug here that there's an important growth opportunity in our intermediate care units, which are often left out of the conversation here. The more that you can actually support in intermediate care units with frontline clinicians, so APPs and other providers, whether that's PA catheters, whether that's temp wires, so on and so forth, the more it allows you to take sicker patients, obviously, in these level 1 centers. And so from an organizational structure and staffing, I think that's absolutely critical.
I'll add on to that I agree with you 100% that the most important thing to have is consistency. You can take all the titles off, the specialties off, as long as you have a similar system that runs year-round, that will provide the best outcomes for patients when there's no questions about who will do what their role is. That being said, we have 11 critical care cardiologists at NYU and Bellevue. And if you don't want any more, we'll hire more of them as well. But our staffing model is currently that we're staffing both the cardiac ICU at NYU and the cardiac ICU at Bellevue with critical care cardiologists for the most part. And the problem, as you guys have talked about, is finding them. That's a challenge. We train them. So the natural next step when that decision was made was to start a fellowship. So when we opened the current unit, we were understaffed. We had a lot of help from other people, and that was great. The consistency was the problem. The dual attending model would have been helpful in that. But I just picked up the slack for a while we started training more people. And as we train them, we hire them, and that's a sort of high-class problem to have, but it's working for us so far.
Yeah, Jim, do you mind a corollary or follow-up to that? So I'd love to hear from you as you could advise, because there's only a handful of programs really in the country that have this land of milk and honey with 10 plus critical care cardiologists. They're concentrated in specific centers, and we're obviously fortunate to have many of them here. But how did you navigate that transitional period? Because I think those are very real challenges. And then I'd love to hear from Ruth to comment a little bit about, from an administrative standpoint, how do you kind of support that effort?
You mean, so when the ICU was hybrid, what it meant generally was that myself and one other intensivist picked up the slack for quite some time. And that was, not the best. As I said, consistency is key. And it meant a lot of extra weekends being available for me and others. And that's fine for a short period of time. You can do that. I mean, burnout is a real thing, but you can do that for a while. But the other issue is that, as someone said earlier, there's not a finite amount of, or infinite amount of pulmonary critical care physicians available, even at larger centers, to come pick up the slack. So that would have been a whole other conversation about pay lines and staffing that would have been just as complex, if not more complex, than just starting my own fellowship, which is another separate conversation about funding that and how to establish those.
So in terms of the hospital administrator perspective, thank you for asking. I congratulate you all for having this conversation in a very collegial manner, because the worst thing, hospital administrators do not like to see turf battles, and especially not in our offices, which happens a lot. So thank you for doing that here in a very collegial manner. I appreciate that. I see the opportunity for who's moving my cheese and those kind of battles, which we hate and often ends up being very costly for hospitals and health systems. So thanks for doing that here. I really think that you need to really understand the costs of all this. And I represent community health systems, and our average margin last year was 1%. So, I mean, grocery stores are making more money than we are, and it's a real problem. So if you could develop the answer is we'd hire whoever is adequately trained who would provide the highest quality care in our ICUs at the lowest cost. I mean, that's really where we are. So I'd really encourage you all to understand that and bring a business plan to your staffing models to understand it, and to also collaborate with each other. I love this team-based care model, which is great. However, overlap becomes very expensive. So I would also ask, where is the overlap? And do we have too many subspecialists in our ICUs? And how do you, and then these are very hard discussions to have. So having them among the societies is really fantastic.
Danny, we have 2 questions.
Oh, great. You can go ahead with the question on this side.
Hi, Sinan Sode, third-year fellow at Iowa, and I'm going to a critical care year on the West Coast after, long-time listener, first-time caller. I got a question from the side of kind of the trainee job applicant area. It's one common through line through the morning is that critical care cardiology or critical care in a cardiology setting is in high demand, which is great for my self-esteem, but talking to some of my kind of national and international classmates, so to speak, it's created a situation where within the job market, there's a lot of opportunities, there's a lot of people that we talk to that say, yeah, we definitely have a position for you, but I don't want to say pitfall because that's a bit pejorative, but when you talk, it's like, oh yeah, we have ICU time, but also we need you in this area, we need you to cover general consults, like the list of responsibilities kind of grows. And that, along with the kind of what Dr. Sinha said about like you can't work 40 weeks in the unit without some consequences, is it reasonable from kind of a self-protection, but also citizenship standpoint, given that we hold a limited resource, to set boundaries on, hey, I want to do this much and these side things, or is it one of those things where we have to take it on the chin for a while and then say after 2 years, I got to back off sort of thing? How do we navigate that in a limited resource space?
I think it depends on how much leverage you have to exert. I think places want you very badly, and I think I'm not going to sit up here and pretend like we have the answers about what the ideal critical care cardiology FTE looks like, because I can say that I think it's different at every one of our institutions, and it's probably different at every one of our institutions from where it was 5 years ago. And so I think you have to answer for yourself what things you value outside of the critical care space. Are there things that you're passionate about within cardiology? Figure out what the exigencies are on the ground. How much do you want to be at that institution? How much are you willing to flex? But I think to a large extent, these are the challenges that any professional faces when they're taking their first job. And I think that we like to pretend that we're special and unique, but I think this is a universal battle.
Yeah, one comment there. I mean, awesome question. And I would just say that you have the leverage in the job market because of the rarity of your training. And I would take those other opportunities to be out of the CICU. You know, I would do your 12 weeks, your 15 weeks, whatever you think is reasonable up front, and then do some general cardiology. Maybe do a clinic if you want. If you like echoes, read echoes. You don't want all of your time to be CICU. That'll last 3 or 4 years at max. And so I don't think that those are layering on. I think you want those opportunities.
I can certainly attest to that, having gone through the process of the past couple of years. So first of all, it's a fantastic time to be a critical care cardiologist, but I will say that a lot of hospital systems are still trying to figure out what to do with us. And what I mean by that is certainly the requirement exists at the level 1 CICUs, but like Dr. Thatchell sort of attested, the level 2 and 3, there's really no necessity for dual-boarded cardiologists at this time. So sort of the word of caution would be that you've essentially narrowed yourself down by pursuing this field to level 1 sort of academic centers from a job prospect. And what you'll realize during the process is no 2 jobs are going to be alike. So you may be at a site where you work with a cohort of critical care cardiologists, with anesthesiologists, with pulmonary critical care doctors. You may staff purely in the cardiac ICU, a cardiothoracic, or a medical ICU. And I think the thing that bothers most hospital systems is what you do outside of those 12 to 14 weeks in the ICU. So it's very important to identify a niche for yourself outside of being a critical care cardiologist. Now, you could pursue sort of interventional cardiology or imaging, but that may also add another complexity, because now are you going to be a 0.5 FTE hire as a critical care cardiologist and a 0.5 as an imager. So just something to think about is, outside of your 1 FTE as a critical care cardiologist, what is sort of going to be your diastole to prevent burnout while you're looking for jobs?
One thing I might add to this discussion as well is that, unfortunately, critical care cardiology is in a tough spot because non-invasive and interventional, we have MGMA benchmarks, right? So you can walk into that negotiation and say, this is what the median is, the 80% percentile in the country. We don't have that in critical care cardiology, and that's something we need to build over the next, upcoming years, because that strengthens us, that empowers us as a community. Many critical care cardiologists are getting paid the same as a general non-invasive cardiologist, which to me is unacceptable. So I think building up that database so we have more leverage when we go into these negotiations. But the flip side of this is, because there is no benchmark, you have some creativity and some room to play in that negotiation as well, so you could leverage that for now.
I would add briefly that this is one of the many, many places where partnering with pulmonary, with AP, CCMPD, and others it will be very, very useful for all of us. So when you're at this job and they're saying, this is what we're envisioning, one thing you can say to them is, well, what is the MICU doing? What's 1 FTE in the MICU? And then to roll back, you have to say to them, well, what do you consider 1 FTE? Is 1 FTE 48 weeks? Because that's not an FTE, that's a calendar year. 1 FTE is 24 weeks, 26 weeks, whatever it is in the medical ICU. Look at literature that's available and look at what the MICU is doing at the site and see if you can roll them in as some help and leverage when you're still negotiating, because you do have leverage in this case in a way that many fresh grads may not have.
Yes, thank you for your question. So first disclaimer, I'm an anesthesiologist. Thank you for inviting me to a little bit outside of my realm here, but a very collaborative, kind of group. So I am the chief of the critical care anesthesia division, and I work in a surgical, basically a CT ICU, but also in a kind of a small-ish community hospital, but previously have worked in academic centers. Our CICU is staffed with cardiologists and no in-house intensivist that rounds there. And unfortunately, the one and only critical care trained cardiologist left is leaving because the ground is essentially not ripe. So for you, as a trainee, as coming out from this, specialty training, it's all great. There is a big demand, as you've identified, but you are right now in a little bit of a silo, and now you're at a point where you have to prove yourself a little bit, right? You're basically the pioneer to your field of this critical care cardiology specialty, which if I had a critical care cardiologist that also had experience or some training or some familiarity with MCS and was comfortable with it, I may invite them to work in the CT ICU as well. And that may be somewhere where you find yourself working. Now, when you are looking for jobs, that goes, I'm addressing all the young trainees and people are thinking going into the critical care cardiology field. You're investing time and money. Nobody really talks about that, because if you're training for 8 years extra while your cardiology docs are already working and making that money and buying houses and doing all sorts of other things, you want to know that when you come out, you can kind of catch up with that. And that's just realistic. That's just life. So just understand that you have to right now be the pioneer, invest your time a little bit and prove yourself, prove your worth, and maybe be in a collaborative model at first, working with pulmonologists and other critical care docs, maybe not in the neuro ICU, that might be a little bit out of the realm as we've talked about. But eventually, you guys will get to the point where you should be staffing the CICU.
Yeah, I realize everyone has almost contributed, which shows you how important of a question was. So thank you for that. A couple things. One, you're not alone. So we designed the AHA statement with this question in mind, so you could literally hand the document over to one of your administrators and have them read it, for good bedtime reading and review it and see if this is an aspiration of what a level 1 CICU looks like, what will it take for us to bridge the gap? So you need to do a gap analysis to bridge it. Number two, because there is such heterogeneity across all of our CICUs, including all the ones up here, you can actually use that to your advantage if you interview at multiple places and use that as the potential leverage when you're negotiating, well, I actually want to do this many weeks here and this many weeks there and this time in clinic and so on and so forth. And number three, this is the power of professional societies. Obviously, that's going to be the next session that's coming up, but to presage the conversation, Chris Barnett, Jake Genser, and many others, leaders in our field, have done a workforce survey that's coming out of the ACC critical care cardiology section that will provide us some data. But yes, we need more data to help advise our other colleagues about how best, what constitutes that true 1.0 FTE. It's not 40 weeks.
Yeah, and one more thing, as an anesthesiologist that also works in the OR and I balance my time in the ICU, that may look different for you at different points in your career. And burnout is real, like anybody who does critical care knows that. Just keep that in mind when you're interviewing at jobs and be flexible, and also encourage the administration and your leaders to be flexible in your role as well.
I say this only partially self-servingly, but another thing to think about is your first faculty job is hard. You have a lot of new challenges that you're facing. Being on your own, having your license on the line every day is scary at first. To add on top of that, building a critical care cardiology section at an institution that doesn't have one is a lot more on your shoulders. And so think about whether that's what you want to do for your first job out, or whether you want to join one of the several shops on this stage that are currently hiring. And say, I need someone who's already built this. I want to have a mentor that's already fought these battles, and then if you want to go and build your own critical care cardiology section elsewhere after a few years, I think you're much more equipped to do so. Not that it can't be done, but that it's certainly a battle.
I would agree with that. I would encourage you to understand the politics of the hospital that you're applying to, because politics are real in hospitals. Moving people's cheese around is very, very hard. And I would ask a lot of questions of the leaders in the institution and your mentors locally.
We have 8 minutes, so we'll get to some questions out in the audience. We'll go over here on the left.
Thanks for taking my question. My name is Brendan Clark. I'm a pulmonary and critical care doctor in Denver. I work in a large private practice. We have 40 intensivists in our group. We cover 10 hospitals. I work with probably over 60 cardiologists across the hospital systems that we cover. And I'll tell you 2 things. So one is I have yet to meet a cardiologist who's interested in critical care in the systems where we work. Number 2, we've never had a critical care cardiologist apply for a job in our group. And so by default in our hospital systems, cardiology critical care is done by intensivists, almost all of who are trained in pulmonary and critical care programs. So I've heard a lot of talk about what we do in the hub, but I work in the spokes, which is where the majority of these patients initially receive care. And I think we all can agree that that upfront care in the initial hours and day of a critical illness really drives the outcomes. And so my question for the panel is, how do we educate and build capacity in the spokes, especially when there's so much happening in this space? I mean, I graduated 15 years ago. I worked in an academic center for 10 years, but I've been out in private practice for 7 or 8 years now, and the technology that's developed in that span is tremendous. So how do you build capacity, and how do you certify that somebody like me and my colleagues can provide care in these spoke centers?
Excellent question. I'll take a first stab. So first of all, thank you for sharing that and being so vulnerable to share it. It's a very stark reality and sobering in many ways. And I think, number one, come join the Society of Critical Care Cardiology. We're truly inclusive, collaborative. I speak on behalf of Dr. Katz, Dr. Semin, and others regarding that. Number two, randomized control trials aren't the only way to change mindsets, behaviors, and honestly, clinical practice. Oftentimes it's really multi-center, registry-based data, quality improvement initiatives, and so forth that are doing that. And that's really being spearheaded by a number of either society initiatives or, for instance, in the case of the American Heart Association, there is a cardiogenic shock registry. Part of the challenge is we don't even have the minimum data right now to establish what it means to be a shock center of excellence. We all think we're pretty good. We show you some data that looks promising and encouraging. The devil, of course, is in the details. And there truly is no one size that fits all. I think one of the key takeaways here is it will be different in your community. And I imagine there should be a time where a critical care cardiologist will join your practice and hopefully will receive the support necessary within that environment to succeed. But in the interim, the question really is how do we build the relationships? So I think one is identifying shock champions at all of the places that you're at. Two, knowing what the level 1 hub, so to speak, is so that you can have conversations serially during that first 24 hours. And number two, there was a shock guidance that came out in ACC last week, published in JACC, that has 1-hour milestones and 24-hour milestones, again, based on best practice. We need more data in this space, but at least provide some guidance to help you in that endeavor. So thank you for your question.
Yeah, I'm happy to add into that as well. So, I'm essentially the hub at the Mayo Clinic in Rochester, but we have a lot of smaller hospitals that we cater to across Minnesota and the Midwest. And essentially what we've sort of done is also come up with a few CME programs for folks where, especially for pulmonary critical care doctors or non-critical care cardiologists. So we have CME programs where we go over sort of advances in CV resuscitation to bring these doctors sort of up to speed with the latest evidence, because agree with you, every year there's more and more late-breaking trials, more and more evidence, and I can understand that would be hard to keep up with. We also offer consultative services where folks can sort of reach out to us and get sort of a primary opinion before transferring folks over.
Yeah, I think having direct conversations with the transferring team to the primary service, having direct provider, physician, or APC conversations, those should all be available to you, hopefully. And if you can't get, if the transfer center isn't giving you a contact, if you are a critical care doc, you should be seeking out a contact if you have questions, because I think that's just sort of that's the critical care mindset and professional mindset in that field.
And you've seen the word collaboration a lot on all the society slides, and you'll see it a lot more over the next hour and change. And that's really part of the ethos of the whole organization, so reaching out, working with everybody. And basically, this is all just a long intro to say that's why there's podcasts and webinars and journal clubs coming out from the society to kind of help spread that knowledge to everyone.
A lot in that question, thank you. We'll try to get to one more.
Sure.
Dr. Gage.
I wanted to push on the administrative and economic argument that we're making. So Dr. Sinha and his colleagues espouse that we can have a co-management model, but that's inherently two physicians, or that we can have a critical care trained cardiologist. I assume the financial impacts of those things are not the same, but I'm actually not certain about that. So employing two physicians, you have salaries, benefits, all the downstream things associated with that. But you also have two people billing RVUs and two people billing critical care time. So what do our administrators want from us? Do they want two doctors seeing the same patient, billing iterative critical care time? Or is it better to hire one person who is going to be the sole person who you have to pay benefits and salary to, but we're not going to bill multiple units of 99291 each day?
And I'd say that like two people billing is probably the best case scenario.
Right, so thank you for that question. Clearly, one person, if in a perfect world, I would hire one person and that person would be responsible for the patients in the unit. I don't know if that's possible in this world that we have today, but that happens every day. Who gets the RVU for these patients? Sometimes if you have a pulmonary critical care doc in our unit and a heart failure doc, they are fighting for RVUs. Again, back to we don't want to have a turf battle in the ICU. So that's a really good question, which I really encourage you all to think about from when you are planning your ICU staffing model. If we can do it with less professionals, that's the way the hospital systems are going to look at it. And if we can do this work with APPs and critical care nurses, again, that's the way we're going to look at those staffing models to bring having everybody in the team work to their top of their license. That's the maximally efficient way to do it. But that's in a perfect world. So thank you for that question.
Even though the pulmonologist, the cardiologist, the pulmonologist, and the heart failure doc can all bill critical care time, that is not advantageous.
Correct. You cannot, same patient, same diagnosis. You often don't get paid you can't get paid for all those different subspecialties, and that's the challenge.
And it's the next iterative thing, I think, Shashank, of when we make these recommendations and scientific statements and guidelines, that we have to then ask these questions, because obviously this is what the payers and our administrators are paying attention to.
100%. Is that
Unfortunately, we don't have any more time for more questions. I'm so sorry. But what a great discussion, and let's give it up to our panelists.